Then we come to the another cause in vascular disorder, namely systemic lupus erythematosus. Here, there is pararticular osteoporosis, there is flexion deformity of the hands, and sometimes you get a swan neck deformity of the thumb, extension, hyperextension at the distal interphalangeal joint. But most importantly, there are no erosions. That's how you differentiate rheumatoid arthritis from SLE, systemic lupus erythematosus. There may be subluxations here also because of the soft tissue changes in the synovium and tendon sheaths. Classical swan neck deformity, hyperextension at the interphalangeal joint and flexion at the metacarpophalangeal joint. And with or without corticosteroid therapy, you can get osteonecrosis in lupus erythematosus. You see the osteonecrosis of the metacarpal hairs. Now we come to the important entity called psoriasis. Of course, clinically you can diagnose, but sometimes arthritic changes come even before clinical changes or skin changes can appear. Look at the erosions at the proximal interphalangeal joints and distal interphalangeal joints. These erosions are peripheral, narrowing of the joint space, sometimes complete destruction of the articular margins, occasionally new bone formation also one can find. The major difference between other erosive type of joints, for example, rheumatoid arthritis, is there is no para-articular osteoporosis in this entity. Psoriasis, classical example of changes in the nails and distal phalanges. Another, the so-called sausage finger. The American describe it as a sausage finger. Diffuse thickening, swelling of one digit, and graphically, why is it? There is increased periosteal reaction, new bone formation, which does not ordinarily occur in other cardiovascular disorders. And these may be bilateral, but never symmetrical. Here again, you may get acrosteolysis or resorption of the distal tufts, but note the erosions at the distal interphalangeal joints. They are bilateral, but never symmetrical. Psoriasis with the deformity of the fingers, particularly the thumbs, eventually may result in arthritis mutilans, which you can find in rheumatoid arthritis also. Jacob's arthritis, where this is rheumatic fever, not rheumatoid, rheumatic fever followed by arthralgias and certain changes in the joints. They are non-descriptive. There are subluxations, there are no erosions, there are deformities. Gout, which is the most important entity. You find, although podagra, it is common in the feet with involvement of the metatarsosphalangeal joints, but you can see in any joint of the body, including vertebral joints. But hands are common. Eccentric erosion with overhanging margins, soft tissue swelling, and gouty tophi are the classical radiological findings of making a gouty arthritis. Again, look at the soft tissue swellings. Look at the pseudotumor of gout. Almost it looks like a complete osteolysis of the middle phalanx of the middle finger on your left hand side. And there are some punctate calcifications indicating gouty tophi. Leishman, it's also a congenital form of gout where there is mutilans of the fingers. The child bites the nails and fingers also. This is a classical example of Leishman syndrome or disease. Pseudogout. Why is it called pseudogout? Because clinically it resembles gout, same type of arthralgias, pain in the joints, etc. Pseudogout, otherwise also called chondrocalcinosis or CPPD, calcium pyrophosphate deposition disorder. Because chondrocalcinosis can occur even in gout or in other conditions also. But in this particular condition, there is calcium pyrophosphate deposition. Whereas in gout, it is monosodium urate crystals. Here, notice at the wrist joint, marked narrow, almost looking like osteoarthritis or degenerative joint disease. But degenerative joint disease, primary, does not generally occur in a wrist joint. It's a mobile joint. This is another example of calcium pyrophosphate crystal deposition disease, or CPPD. And you could see the small irregular type of calcifications at the synovium of the metacarpophalangeal joints. So, in other words, you can get calcium not only in the cartilage, you can get in the synovium, bursae, ligaments, eventually leading to degenerative joint changes. This is another important entity called Wilson's disease due to disturbance in copper metabolism, and copper accumulates in the articular margins and in the kidneys, in the liver, in the cornea, so-called Kaiser-Fleischer rings around the cornea, and in the articular changes include irregularity. Look at the fringing and irregularity of the scaphoid and other carpal bones. Similarly, distal articular end of the radius. In no other entity you can get this. Occasionally you may get osteonecrosis also. And in some cases, in children you can get rickets, and in adults you can get osteomalacia due to hepatic and renal changes. And then let us see Wilson disease, what are these skeletal changes? As I said earlier, rickets and osteomalacia because of the changes in renal and liver cells, osteoporosis, fringed articular margins, which I showed you earlier, fragmentation, and small ossicle formation at the articular ends. Look at the Kaiser-Fleischer rings around the cornea, the brown or copper colored pigment, and also the changes in the nails, pigmented changes. And then fluorosis. There are certain endemic areas in this country, particularly in Andhra Pradesh and Punjab. And what happens? The bones, radiologically, you find diffuse sclerotic bones. But then, how do you differentiate from marble bone disease or pycnodysostoses? Here, the calcification of the ligaments is most important. That occurs. Look at the irregularity of the periostral surface of the phalanges. Now we come to infections. Viral, smallpox, of course today we don't see smallpox. Polio, soft tissue changes, and thus resulting in bone changes. And bacterial, specific bacteria, TB, etc. Fungal, actinomycosis, nocardiosis, sporotrichosis, parasitic, hydatid, etc. Tubercular dactylitis. This is spina ventosa. It was described in the literature, that is expansion of the phalanx as if the air is injected into it like a balloon. That is one of the classical examples of tuberculous dactylitis. Leprosy, early bone changes simulate sarcoidosis. Similarly, nutrient foramen are big, lytic changes in the nasal bones, in the hands. Later on, you get deformities and a neuropathic type of joint. For example, leprosy, including, how can you tell it's leprosy? Or you can diagnose this, it must be a neuropathic joint. And then there is a lot of soft tissue swelling, osteomyelitis, new bone formation, disruption of the joint. All these are superimposed due to infection and neuropathy. Sarcoidosis. Somehow, sarcoidosis is not uncommon in India, but bone changes are uncommon as compared with the Western countries. But if you find bone changes, acrosteolysis you can get, lytic changes, cystic changes, sclerosis, mixed areas of lysis and sclerosis, soft tissue changes, and including swelling, but no calcification. Now we come to the other systemic disorders, namely endoacromegaly, hyperthyroidism, for example, thyroid acropathy, hypothyroidism, hyperparathyroidism, hypoparathyroidism, pseudo hyperparathyroidism. Diabetes, hypertrophic osteoarthropathy. These are all some of the entities that you can get. Acromegaly, classical, spade-like hands clinically, but radiologically you find tufting of the distal phalanges, exaggerated tufting. And then of course, the joint space between the metacarpals and phalanges is increased because of the hypertrophy of the cartilage. Also, some people describe as sesamoid, increased sesamoid or enlarged sesamoid at the first metacarpophalangeal joints. The sesamoid index is increased. Strong suspicion leads to early diagnosis. Unless you suspect, unless you keep in your mind the entity, you can't really diagnose these entities. Hyperparathyroidism, classical in the sense, erosion, subperiosteal resorption of the bone is the classical pathological change that occurs in radiographs. Because of that, you can bone resorption, subperiosteal bone resorption, subchondral bone resorption, and distal phalanges also resorbed completely. Again, hyperparathyroidism, look at the subperiosteal resorption of bone, particularly on the radial aspect of the index finger. That's early sign, but advanced changes, look at the tufting, but it is not exaggerated tufting as you see in acromegaly. It is a resorptive type of tufting because part of the cortical bone is resorbed, you find tufting of the bones. Secondary hyperparathyroidism. Today, secondary hyperparathyroidism is seen more often, encountered more often because of the renal dialysis, and these chronic renal failure patients live longer, and that's how we get changes of secondary hyperparathyroidism, otherwise called renal osteodystrophy. What are the changes? Soft tissue calcifications. Although we can get soft tissue calcifications in primary hyperparathyroidism also, but these are more common in secondary hyperparathyroidism. And as you see in hyperparathyroidism, here also there is bone resorption. Vascular calcifications are more common in secondary hyperparathyroidism. And today, brown tumors are also more common in secondary hyperparathyroidism. Now, hyperthyroidism, how does it reflect on hands? Advanced maturation. Say the bone age is 5 if the patient's chronological age is 3 years. That's how advanced maturation of the bones. For example, this child is 5 years old, already you see about 7 carpal centers. Thyroid acropathy, namely periostosis, occurs with thickening of the skin. That is one of the complications of thyroid therapy. Hypothyroidism, where there is thyroxine levels are low. Clinically, it manifests as a myxedema, and in children particularly, cretin, that is retarded bone age. For example, look at this wrist, 2-year-old girl, hardly you see 2 carpal centers, which you may see at birth or in infancy. This is retarded bone maturation. Hypoparathyroidism, where there is brachydactyly. Look at the widening and shortening of the metacarpals and phalanges. Typical example of hypoparathyroidism, although this may simulate, earlier remember, peripheral dysostosis. But there, the size of the bones is not this big or this large. Pseudo-hypoparathyroidism, that is no response to regular parathyroid hormone. Short 4th and 5th metacarpals. 15% of hyperparathyroidism patients develop pseudo-hyperparathyroidism. Hypercorticism, either secondary or primary. Primary in the sense there may be a cortical tumor, secondary due to corticosteroid therapy. Hypercorticism, there is advanced maturation of bones, marked osteopenia or osteoporosis of the bones. Turner syndrome, due to hyperplasia of the ovaries or in absence of the ovaries, the so-called metacarpal index. If you draw a line at the heads of the 5th and 4th metacarpals, normally it has to go and bisect or dissect the 3rd and 2nd metacarpals, whereas here it goes off. Turner syndrome, there are other various skeletal changes, hyperplasia of body of C1, drumstick appearance of distal phalanges of the hands, almost simulating clubbing, enlarged medial tibial plateau with a depression at the knee joint, pes cavus deformity. These are some of the changes. Again, Turner syndrome, look at the acute angle at the wrist, radiocarpal angle. Normally, it should be obtuse angle. Here, it's acute angle. Other metabolic bone disorders, vitamins, either hypervitamins or lack of hypovitamins, minerals, metals, hormones, enzymes, muscles. These are some of the entities that can produce metabolic changes. For example, rickets, hypocalcemia, lack of vitamin D. Look at the metacarpal cup, metatarsal and the metacarpal, and here in this particular case, there is cupping of the ulna and radius. Dilantin therapy also may produce rachitic changes because of the changes that occur in the liver. Fluorosis with rickets, particularly in certain countries, it's not just fluorosis occurs because these children also have rickets. It's not just an association, but it is a cause and effect of fluorosis. This one is healed rickets. When the mothers or the physician is over-enthusiastic, they may give plenty of vitamin D, which is not really required, more than required doses, and that produces sclerosis at the metaphyseal ends of radius and ulna. The deformities persist, but the bone ends are sclerotic. The cupping is gone. The distance between the epiphysis and metaphysis is gone. And also notice, it may produce osteoporosis of the bones. Hypervitaminosis D, dense metaphyseal bands, as we said earlier, sclerosis of the bone, cortical thickening, and soft tissue calcifications may also occur. Renal rickets, as we said, in chronic renal failure, you can get in adults osteomalacia, in children renal rickets, because the final metabolism of vitamin D occurs in the kidney. Dialysis, patients who are on chronic dialysis may develop certain cystic changes in the metacarpals or even phalanges. Scurvy, this is due to lack of vitamin C. Of course, today is rather rare, but still occasionally you may see. It is quite opposite to rickets in the sense, although there are some similarities, namely metaphyseal cupping and corner spurs, but the major importance is there is no increase in the distance between the metaphysis and epiphysis. Because there in rickets, there is hypertrophied osteoid to compensate for the lack of calcium. Here the lack of vitamin C, lack of protein, the bones are of ground glass appearance. Osteoporosis may be present. Sometimes what happens, all the vitamins are deficient. Both vitamin D and C and A. That's how these people have some superimposed changes of lack of vitamin C and D. Osteoporosis, common both in adults and children, but senile osteoporosis, postmenopausal osteoporosis, they may reflect upon the hands also. The osteoporotic bone is generally lucent. Not only lucent, hyperlucent. And then the cortex is thin. The differentiation between the cortex and spongiosa is great. It is not a ground glass appearance that you find in osteomalacia or rickets. That's the major difference between osteoporosis and osteomalacia. Primary hyperoxaluria, there is oxalosis, there is glutamic glycosylic transaminase is deficient. Radiological findings, coarse rarefaction of metaphysis, classical, cystic changes in metaphysis, sclerotic epiphysis. But you see, most of the changes that occur in oxalosis are due to secondary hyperparathyroidism, where you can get osteosclerosis, osteomalacia, and other cystic changes. Again, oxalosis, look at the metaphyseal bands of sclerosis, such as you find in hypervitaminosis D also. Pseudoexatrophy, or otherwise called reflex sympathetic dystrophy syndrome. In myocardial infarct you can get, or in old fracture you can get. Minor trauma without a fracture because of the immobilization you can get psoriatic atrophy, namely osteoporosis of the bones, localized swelling. Occasionally, if it is advanced, even subperiosteal resorption of bone may occur. Look at the para-articular osteoporosis, simulating as if it is a rheumatoid arthritis, but it is only one hand. It's all the joints that are involved. Soft tissue swelling is diffuse, not spindle-shaped. Hypertrophic osteoarthropathy, or otherwise called clubbing, various causes, not only pulmonary, cardiac, and metabolic causes also can produce this hypertrophic osteoarthropathy. Diffuse periostosis of all the metacarpals and phalanges, but it spares the distal phalanges. It does not involve the distal phalanges. Hypophosphatasia, that is excretion of phosphorylethanol amine in the urine. It is a developmental or congenital condition, and it simulates often the rickets. One has to be very careful. But with vitamin D, it does not heal. And hypophosphatasia, there are several varieties: neonatal, infantile, childhood, adult. And as the child grows into adulthood, the severity decreases. Look at the metaphyseal cupping, almost simulating rickets, but neonatal rickets is rare. It is juvenile. Look at the irregularities at the metaphyseal ends, not complete metaphyseal cupping, eccentric type of cupping. This is again a 11-year-old child. Look at the lucencies and look at the distance between the metaphysis and epiphysis increased with spurring. Hematological conditions reflecting upon the hands, sickle cell anemia. Because of the infarct, you may get premature fusion of the epiphysis, lack of growth, that's why you get short metacarpals or short phalanges. Sometimes because of the osteomyelitis also, you may get premature fusion of the epiphysis. Sickle cell dactylitis, you find like osteomyelitis, but there is no myelitis part, only peri-osteitis is there, soft tissue swelling is there. Cooley's anemia or Mediterranean anemia, classical example of hypermedullosis, in the sense hypertrophy of the bone marrow. That's why there is a bulge of the metacarpals and phalanges, and there is a mosaic type of appearance of the trabeculae. That is classical of thalassemia or Cooley's anemia. Another example, severe example of Cooley's anemia, diffuse lucency and mosaic appearance. And then now we come to miscellaneous examples, in the sense systemic disorders reflecting upon the hands. Paget disease, monoarticular Paget is known, but in general Paget disease is systemic disorder. Multicentric reticulohistiocytosis, hyperlipidemia, toxic causes. For example, we already have mentioned fluorosis, lead poisoning, cadmium poisoning. They may reflect upon the hands, amyloidosis, and certain neoplasms, systemic neoplasms like leukemia, lymphoma, myeloma. Paget disease. This is, notice the one important thing in Paget disease is there are three phases: osteolytic phase, osteosclerotic phase, and mixed phase. This is mixed phase. There is sclerosis of the proximal phalanx of the ring finger. There is expansion of the proximal phalanx of the little finger. There are lytic changes. So this is a spectrum of pagetoid changes in the bones. Of course, final stage is malignancy. Another Paget disease, diffuse sclerosis only. Also notice the changes occur all the way to the articular end of the bone. That is important. The fourth metacarpal and the proximal phalanx of the thumb. Here, sarcomatous changes in Paget disease, like any other osteosarcoma. More often it is the osteogenic type of osteosarcoma, although osteolytic type of sarcoma also can occur. Giant cell tumors are also common, but mostly they occur in the facial bones. Multicentric reticulohistiocytosis, the deformities of the hands, and soft tissue changes, flexion contractures. Hypercholesterolemia, mostly soft tissue deposits of hypercholesterol and minor erosions at the metacarpals and phalanges. Hyperlipidemia, again soft tissue changes and destruction of the bones. Same lytic changes can also occur in the bones. Amyloidosis, amyloid arthropathy is known as a terminal event, although primary amyloid arthropathy can occur, but here is a secondary amyloid arthropathy after consequent to multiple myeloma. Soft tissue changes, erosions, nothing classical about this unless you think of the entity or you think of the pre-existing disorder. Neoplasms, benign, malignant, primary and secondary. Maffucci syndrome, that is enchondromata with hemangiomata and calcification. Occasionally, you may see even malignancy in the GI tract and bones. These calcifications are classical of chondromata, and some of the calcifications in the soft tissues, they resemble Philippolis because of the hemangioma coexisting. Earlier dyschondroplasia, look at the changes, the linear changes in the phalanges. That is because of the persistent existing of the cartilage that produces linear changes. Osteochondromata or exhastosis, it can occur anywhere in the body, although knee joints are common, but here also you can get at the phalanges multiple osteochondromata or exhastosis. Leukemia, leukemic changes, leukemic infiltrates, and sometimes you find in the hands sclerotic changes with leukemic bands proximal to it. It is astonishing how little reading a doctor can practice medicine, but it is not astonishing how badly he may do it. Take this for example. Hand of a 16-year-old has carcinoma of the lung. Metastasis distal to the knee joints and elbow joints is rather rare, but occasionally in carcinoma of the lung, carcinoma of the cervix, carcinoma of the breast, you can get distal metastasis. It is one example of metastasis to the proximal phalanx of the middle finger from bronchogenic carcinoma. Ultimately, last picture. Always our talks should end with some quiz, some intellectual stimulation to the audience. What is the diagnosis? This is the hand. If you notice carefully, look at the radius and look at the thumb. The thumb is on the ulnar side. It's not on the radial side. This is because the patient had a disarticulation, traumatic disarticulation, and the doctor wanted to reimplant it. In reimplantation, he has missed and reversed the hand and fixed it to the forearm. You understand the whole problem. It is a miscalculation or misunderstanding. He reversed the hand and stitched it to the forearm. That's the diagnosis.